evening,
Okay.
everyone. I welcome you all for today's webinar on Oncology Cancer Treatment Updates 2023. With immense pleasure, I would like to invite Dr. Kapil Goyal, who is Consultant Medical Oncology, Rajiv Gandhi Cancer Institute, Niti Bagh, Delhi, for the welcome and introductory note. The stage is all yours, sir.
Good evening, everyone. So it is my immense pleasure that we have gathered together on in this evening to discuss some important updates in the oncology. So today we'll be discussing some recent advances in the area of oncology. As we know that oncology, especially in this era of immuno-oncology, it is a rapidly evolving field, and every now and then, every year, there are some major conferences in which the new researches and new data they are keep on coming, and that is why as an oncologist and a treating physician for a benefit of our patient, it is essential that we are up to date with the recent guidelines and what are the recent benefit and recent data that is being presented. So keeping that in mind, said I think we have uh, arranged for this symposium so that we across many medical oncologists across this country we can have a meeting together and we can discuss what are the advances going up. So in this series, so we'll be having some talks. So there are four talks in total. So first talk will be given by Dr. Sakib Shah, who is a consultant medical oncology in Paras Hospital, Srinagar, followed by another talk by Dr. Anshul Gupta, who is a consultant medical oncology in Max Hospital, Vaishali. And then we'll have another talk by Dr. Rakesh Sharma, who is associate consultant in Max Hospital, Saket. Finally, I will be talking about some data regarding osimertinib in lung cancer. So, I am, as already introduced, I am a consultant medical oncologist in Rajiv Gandhi Cancer Institute, Nitiba. So, without wasting any further time, I would like to request and invite Dr. Sakib Shah. Dr. Sakib, are you online?
I am online. Can you hear me?
Yeah. Hello,
Just
hello.
give me 1 minute.
Welcome,
I
Dr.
just
Sakib.
switched the welcome. Thank you, sir. Thank you.
No problem.
Thank
No
you.
problem, sir. Take your time. Take your time.
Just 1 minute. I just reached home because it's very chilly in the Srinagar. You can sometime come and
No,
enjoy
no,
the winter here. Give me 1 minute so that I can
okay.
rush to my room and start
Sure. No problem. No problem, Dr. Saab. Take your time.
this now because it was hectic OPD today.
No problem. No problem. We all know that
Just 1 minute.
you are
One
a
minute.
busy oncologist. Yeah. No problem. So just to give
Okay,
a brief
we
introduction
can start
about
right
the
now.
topic that.
We can start right now.
Okay. Yeah. So I invite Dr. Sakib Shah, who's a consultant medical oncology in Paras Hospital, Srinagar. Dr. Sakib will be talking about molecular biomarker testing in lung cancer. So I welcome, Dr. Sakib, and this is our first interaction online or offline. So I hope that we gather so much information in this symposium and we get to discuss newer things coming up in area of lung cancer, and we hope to meet in person very soon. So all yours. Over to Dr. Sakib.
Can you? I have already shared my presentation. Can you people do slide share, please? So today's topic is about molecular testing of lung cancer. What we do stand in 2023. So our topic will be divided into four parts. One of them will be the what is the current scenario of lung cancer in India? What are the biomarkers available with us? And third, what is the evolution of these biomarkers? And what is the key takeaway? Next slide, please. So we look at the burden of lung cancer in our setup. In world, it is still number one. We have lung cancer, which is number one in males. In overall, the world data is there from Globicon 2022. 20. But in India, we can see that the number of lung cancer in males, it stands fourth, and it constitutes 5% of all lung cancers. And in females, it is almost slightly lesser incidence. So we can say lung cancer still tops overall after breast cancer, oral cavity cancer, and gynecological cancer and lung cancer. Next. And we can see that overall prevalence of lung cancer, the cases have increased. If we see the literature of 2004, it ranked all, I think, 12th. Now it has gone up to the second in the males and fourth in the females. Next. And where do we stand in the lung cancer currently? What we have is that overall 70% of the patients come at stage 4, and we have data in stage 4 that we have a driver driven cancer. That is, the cell, they get mutation from a particular driver, and then they get transformed into cancer cell. That is known as the driver theory of lung cancer. So we have two mutations. One of the mutations is a driver mutation, which is non-genetic. It is actually non-germ, right? It's a somatic mutation occurred by lung tumor cell. And another is passage mutation, which are additional non-specific mutations. So we have data from French study that 50% of these mutations can be targetable. And we have data from USA that 50 to 60% of the lung cancer will have a driver mutation. And what they have seen, the most common driver mutation they have seen is a RAS mutation, in which point mutation of glycine and 12 exon on G12C is found in 13% of the cases, followed by the EGFR mutation. And then ALK is a third common mutation. And we have almost driver testing of almost 12 plus genes at this point of time, for which targeted medications are available. And still we have 31% of the patients in the stage 4 where we don't know the driver mutation. Next. And why do we do driver mutation? There are two. This is a French data actually. They found that when they use the first generation TKIs, which are actually the drugs for the driver mutation, they found that the median survival, progression-free survival was 11 months, 7 months versus 11 months in those patients where driver drugs were used versus those where conventional chemotherapy was used. So we had a 4 months of PFS benefit. And later on, they found in the data that they have an overall survival benefit of 11 versus 16 months. So we can see the two curves separating that those patients who had a targeted mutation available, the overall survival was 18.6 months versus 11 months. And there's another study by US. They found that those patients who have a driver mutation, the overall survival is 3.5 years. This is when they incorporate the latest third generation TKIs. And they've also found that those patients who have a driver mutation, if they are treated with the chemotherapy, that not by the actionable targeted drugs, but chemotherapy, versus those there are no drivers available, still their overall survival is better. It is 2.5 years versus 2 years. So driver mutation is not only the prognostic indicator, but also as a predictive indicator. They do better with the chemo also. They do better with the targeted drugs also. Next slide. So we can say one thing what is common with these driver mutations, what molecular testing we do as of now, we have EGFR, we have ALK, we have ROS, we have HER2, we have MET, we have RET, we have NTRK, we have NRG1, and then we have a downstream pathway. This is a pathway. We have RAF mutation and MEC mutations, which are the parts of the mitogen activation kinase pathway. So all of these testing we do at this point of time in the non-small cell lung cancer. And one thing is that these mutations are almost mutually exclusive. That is, one mutation does not affect the presence of another mutation. We have rare cases that we can have EGFR and ALK together, but there are rare cases where we can have a EGFR and RAS together, but most of the time they are mutually exclusive. Next. So what are the guidelines? Although these are data of 2028, then ESMO data of 2020, and then NCCN data of 2021, and also ESCO data of 2018, which was in the slides provided by the AstraZeneca. What we test at this point of time, we have EGFR testing available, ALK, ROS, BRAF, MET, RET, NTRK, KRAS, and we do ASC for BDL1, and we have few more NG and NG1 also available, and HER2, which is not mentioned in the slide, which is also available, HER2 mutation. So these are the currently available biomarkers where we have a treatment available. Next. And this is what the slide I got from UpToDate. They found that what are the techniques available. So these are the 12 markers at this point of time we do for 12 gene lung panel, which are available, and that different techniques we use molecular techniques. The old one was tissue PCR sequencing, which was known as Sanger sequencing. It's old now, which is not used correctly. So currently we have two types of techniques available for molecular testing of lung cancer. One is tissue analytic PCR. That is another is fish testing. Then we have IHC, which is applied for some of the lesions like ALK or PDL1. Then we have NGS, which is both RNA-based NGS and DNA-based NGS, which is almost applicable to all of the mutation except PDL1, where NGS cannot be done. Then we have a liquid biopsy. So liquid biopsy gives results for few of the mutations, but currently it is validated only for EGFR as of now. And but the techniques are improving. So liquid biopsy is also incorporated in other mutations. So we will see in the next slide what are these. Can we go to next slide, please? So we had old technique which was known as DNA sequencing, also Sanger sequencing, where we use it to see a sequence of particular mutation with comparison to a particular data saved. So it was very slow. It used to have a lot of it used to take a lot of time. Then eventually we improved the technique by following PCR. Which we actually use for EGFR, where we see that once we have EGFR mutation, we amplify the EGFR gene, and then we use see it with the our database, that is PCR technique. And then we have NGS, which is actually a more molecular technique where it is very rapid, where we have lots of data saved of all the mutations. And then we once we amplify the DNA, we see the result with the stored information. So it has one advantage, that it is rapid. It picks it is much more sensitive. If tumor content is low, still it can be used, and it picks additional mutations. And liquid biopsy can also be used for the same. Then we have RNA sequencing panel. It is actually also based on NGS, but it can pick. It is more sensitive for ALK, ROS, RET, and NTRK. And later on we have IHC for and fish, which are more for PDL1, ALK, as well as ROS. Next slide. So what how do we diagnose? This is the most important. First of all, once a patient will come as a case of lung mass with plus minus mediastinal nodes, I am just making a fake scenario with suppose bone mets or liver mets or maybe brain mets. We do a biopsy. So first of all, most important thing is that the this concordance with the resultant of biomarker, that is driver molecule, compared to that of metastatic size, there is very less. Only 1 to 2% is variation. That if we have a patient of lung with liver mets, if we take a biopsy of liver, the change of driver will be there. It's almost very rare. Most of the time, the drivers don't change. Like we see that in other tumors, drivers don't change. First, this is the most important thing we have to remember. So once we take a biopsy, we see whether it is non-small cell carcinoma or small cell carcinoma or any other histology. Once we see a non-small cell carcinoma, we confirm it with ISC, whether it is squamous or non-squamous like adeno. For squamous, we do ISC of P40 plus minus P50, P63. For ISC for this adeno is TTF1 and absent. Actually, our aim should be first that we should preserve as maximum as tissue for the molecular testing, and we should apply minimum markers for the ISC. So most of the time, most of you will be writing to use less markers. Kindly do P40 plus TTF1 plus minus napsin, just to confirm that our tissue is preserved for molecular testing. And then once we have a biopsy available, we go for NGS based testing, or we can go for individual testing. That we discuss which is better. Plus, we have to keep some tissue preserved for PDL1 expression. So we have problem that we have two other options, bone biopsy. But the problem is that because of decalcification and degradation of DNA, because we use DNA for or maybe RNA for the molecular testing, it is not that much feasible. And second thing is liquid biopsy. The option of liquid biopsy is slightly limited. It is limited to few other mutations only, and its sensitivity is 60 to 70% only, because it can still miss some cases. So next slide. So one more thing is that once we have a tissue, we did a molecular testing. We confirm it is adenocarcinoma or squamous cell carcinoma. We have in all adenocarcinomas, molecular test study is recommended, but in squamous cell carcinomas, it is still recommended. We have still got a 5% chances that we can have these driver mutation, especially in light smokers or where tissue content is less. In adenocarcinomas, there are up to data say up to 50% or 60% we have chances of getting these mutations, especially in females, which is more as compared to males, and those in non-smokers is more as compared to smokers. Even if patient is smoker, the chance of getting EGFR mutation is still one-fourth as per the data. Uh, we have if we are not able to get a biopsy, we have another option, liquid biopsy. The problem with difference between tissue biopsy and liquid biopsy is that in liquid biopsy we have to be invasive. We have to go for CT guided or biopsy or bronchoscopy or image guided biopsy of the liver where the metastatic site is present. But in liquid biopsy, we only need a 10 ml of ml of blood. In the issue is rechallenge. Suppose we get a less tumor content, or we have many of the times once we do biopsy, have tumor not present, TPN is tumor tissue not present, TNP is written. So tissue getting a repeat tissue is slightly invasive, but liquid biopsy it is easy to do. But the problem is that sensitivity. The sensitivity of liquid biopsy is slightly lesser as compared to the sensitivity of solid tumors because we have a good amount of content of tumor. Even if 1% of tumor is present in the tissue, we can do all the histology as well as genetic these driver mutation tests and PD-L1. But the liquid biopsy requires circulating DNA. Uh, for that, genetic testing, we should have at least good quantity of circulating DNA. If it is less, the testing will not be validated. Third thing is that the biology of the tumor only can be got from tissue biopsy. That is, whether it is a non-small cell carcinoma or whether it is adeno or squamous, which is at this point of time challenging for the liquid biopsy. And one more thing is that the data for starting these drugs is more for liquid this on solid is on the tissue biopsy rather than on liquid biopsy. So these are the advantages of having the solid tumor biopsy rather than liquid biopsy. These are the pros and cons of the current scenario available. Next slide. Next slide. So can you go back to the previous slide? 1 minute. So one is what should we do? Should we go for an once we have a tissue, once we have a available tissue, we have diagnosed a case of adenocarcinoma lung or small squamous cell carcinoma lung. Should we go for a single gene testing or should we go for a multiple gene testing? This is a big debate, and what we have found in the literature about this is they found that we have to weigh risks versus benefits. If we have very small quantity of tumor available and we have option to start chemotherapy plus immunotherapy, at least we should minimum go for EGFR plus ALK testing, because if EGFR is positive or ALK is positive, then it is difficult that the immunotherapy will work in that cases. So minimum requirement for starting immunotherapy is that EGFR ALK should not be positive. Although data is emerging that if ROS or MET are positive, then immunotherapy still does not work. But that is still that talking about that is ahead of time. So if you have a very limited amount of tissue present where and repeat biopsy is not possible, at least we should do mandatory EGFR by PCR and ALK by ISC. ALK reports you can get in 24 hours by ISC, at EGFR by PCR you can get in 7 days. That is but tissue is not available. But if we have ample amount of tissue available and which is right now available possible because of modern biopsies techniques, then NGS should be done. And right now, TAT time for NGS is 10 to 14 working days. Next slide. So, what are the different mutations we see in the lung cancer? So, first is EGFR mutation. So, what are the specimen available? We can have fresh formalin, paraffin, paraffin amyloid blocks. We can have on this. We can have fresh tissue available. We can just make a smear and do PCR for that. We can have alcohol fixed specimen for that, and we can even have a cytology and we can make a cell block for that. And we already discussed that concordance is very less if we take a tissue from the primary side or from the metastatic side. Only it is very rare that the two tissues will have different mutations. Next slide. So Oh, what do we do? What we have? Why do you do EGFR testing? So on EGFR testing, we can have exon 19 deletion. We can have exon 21 L5 L85 AR point mutation. We can also have rare exon 18 mutations, and we have exon 20 mutation. Exon 20 is a heterogeneous group. It constitutes 4% of all mutations in lung cancer. If we have a 70% of exons, other exon EGFR mutations, 4% are exon 20 mutations. We can have, and it is also heterogeneous group, and one of them is T790M mutation, which can be seen if upfront present, or it can be upfront present, or it can be occurred. If upfront present, then it leads to resistance for first and second generation TKIs, and we have to rule out familial lung cancers because upfront mutation can be seen in familial lung cancers. But second thing is that exon mutations, we do it in two scenarios in the metastatic lung cancer. First is upfront, and second thing is if the tumor progresses on first or second generation TKIs. At that time, we have to repeat a biopsy from the progressive site and see what has happened to the tumor. The tumor can, in 50% of the cases, can occur T790M mutation, which is exon 20 mutation. We can have exon 19 mutation, then patient can occur exon 20 mutation. That is one scenario. Second scenario, we can have MET amplification where we have to give chemotherapy. And third thing, very rare, we can see in 5% of the cases of this, there can be transformation to small cell lung cancer, which we have seen cases. Now, this is the overview of exon 20 mutation. So we do it by two tactics. If one is PCR and there is NGS. NGS has advantage over PCR that it picks additional other mutations, where PCR picks only fixed mutations, where we have like exon 19 mutation, exon 21 mutation, or exon 20 mutation like T790M mutation, or T7 exon 20 deletions. And during the once a patient progresses, then only specific set of mutation can be picked on PCR, but NGS can pick all the mutations. Second thing is that now we have a data. Can we go to next slide? That in the early lung cancer, after surgery, we have data from Aurora trial that we have to do EGFR testing because adjuvant osimertinib has a role. So in when resected lung cancers, we have to do EGFR testing because it helps us to detect a subset of patients who can benefit by adjuvant osimertinib. So it is recommended in adjuvant settings also. Next slide. And what is the advantage of NGS or PCR? We discussed that one study showed that 48% of the EGFR exon 20 mutations were identified via NGS, which were missed on PCR. That is the advantage of NGS. So we can get an intrinsic resistance. And one thing is that one out of 17 most common EGFR exon 20 mutation variants, only 4 can be identified for PCR. 13 can still be missed, which can respond to the newer drugs. We have mobocertinib, or we have imatinib, and we have osimertinib available for T790 mutation. So NGS is always better than PCR, although slight time consuming is there. Next slide. So ALK arrangements. So ALK rearrangements, Alcoma's family of non-small cell lung cancer. Can we go to next slide? There are two things. Should we go for fish testing or should we go for ISC testing? There's a good amount of data that once if we go for the fish testing for ALK DSF3 mutation, what they have found that the ISC coordinates is with fish is almost 99.99%, and the false positive rate is only 0.1%. ISC is very rapid, it is less expensive, so it is worldwide adapted. There is some studies say that if we do it by ISC, then we don't need to do it by fish. We don't need to repeat it by fish. So all the both pathways are equally validated. If you do by ISC, then if you do by fish, although they have seen few cases which are positive on ISC but negative on fish, but we have to treat them like algal-driven tumors. The next slide. And what is the role of NGS in ALK? Before I go to Ross, what is the role of NGS in ALK? There has been the trend, like we have in EGFR mutations, we have ALK rearrangements. The trend is that if there is progression of first generation, second generation, many of our patients will still on second generation TKs like ceritinib. So NGS can detect further mutations which can be sensitive to lorlatinib. That is one advantage of NGS. We can do that. That is one advantage of NGS in the lab settings. Next slide. So ROS arrangement. ROS. Now it is another thing which we used in past. present, and now we have another mutation. But it was long back. ROS was going on, that is C-ROS, which is found in 1 to 2% of the lung cancers, especially non-smokers, young patients, and in adenocarcinomas. And here, what happens that a ROS gene gets translocated, genetic translocated to any other domain, like CD74 is the most common domain, where it gets translocates. And they have found that this ROS, which is more common in medullary carcinoma of thyroid, or again also in the papillary carcinoma of thyroid, this rearrangement is almost same as that of a thyroid family, although behavior is slightly different. There are two ways of testing, whether we can test it by ISC or whether it can test by fish. So what they say that if a tumor is positive on ISC, it is we don't have to start treatment. We have to always confirm the fish, because the detection. Why do we do ISC? The question will be like that. It's cost effective, because what we say that if we do ISC, we get a rapid result. If ISC is positive, then the patient goes for fish testing, and fish will take another week. But if ISC is negative, then we don't need to do fish. So it saves the time of the patient to screen it for the ROS mutation. Next slide. So we can again quickly revise that EGFR we go for PCR testing. It is and NGS testing. We can get extra molecules for extra drivers on NGS. Then we have ALK. We have ISC is very good for ALK, although NGS is still applicable for that. Then we have ROS. We can screen by ISC and then confirm by fish, or we can do NGS. Now we go to another mutation. This BRAF mutation, I think. I think it's RAS mutation. I think it's a RAS pathway because stream coming very small. So RAS is a downward stream pathway. It is found in almost 30% of the lung cancer. And if EGFR alkyl positive, then RAS is negative. They're mutually exclusive of each other. And what we see in RAS pathway, we normally follow see a codon mutation of codon 12 and 13, and which for which if we have a G12C variant found, which is found in 13% of the patients, we have a treatment option available for that. RAS mutations actually, we have a RAS family of protein. We have KRAS, which is distant rat virus. We have HRAS, which is Harvey rat virus. And we have NRAS, which is almost found in 1% of the patients. This RAS is more common in smokers, which is found in 20-25% of the smokers. And what data they have shown that if it is found in early lung cancer, RAS mutations, it does not affect on overall survival. But once this is found in the patients who have metastatic lung cancers, the overall survival is less. We have a drug we have seen, sotorasib, which has been available for the this G12C mutation. It has been used as a second line as of now, which has found that there is hazard ratio of 0.65, I think, it has improved the survival. So it helps us to identify the targetable mutation for KRAS, and it has got the predictive overall survival poor prognosis in patients who are metastatic. Can we go to next slide? And this KRAS testing is done by also NGS. So BRAF testing is also it's actually we can see the pathway. We have a EGFR, which goes to the CNS. Then we have a RAS
Chiếc
and then
hàng
RAS.
vừa mới ra mắt vào tháng 6 năm 2022 của Seco và bên Hồ Quang Lâm sẽ cùng các bác.
Hello? Some noise in the background. So we have a EGFR, we have a RAS pathway, which we discussed it. Then we have a RAF pathway, which is always associated with the MAC. It's a downstream of MAKP pathway. So it is involved in regulating the proteins for survival of the cell and cell proliferation. So we have many BRAF mutations. It is found in smokers, 1 to 3% of the population. And most common BRAF mutation we found is V600E. This V600E is found first in this B600V has better prognosis as compared to non-V600E mutations. We can have V600K mutations, other mutations. And they are found in adenocarcinomas, 1 to 5% of the cases. We always detect this by ISC, but ISC and PCR are generally accepted methods, but NGS always preferred method because it gives us better overview of the genetic mutation. And we have many class of drugs available. We have darbepoetin plus tremetrine available. We have encorafenib plus biometric available for the BRAF pathway. But if we have known V6A pathway, we always follow chemotherapy. That is because these molecules have not shown good response to the
Dr.
these.
Saqib requests you to conclude your presentation in the next 2 minutes, please.
Okay, next slide. We have the MET pathway, which is found in 1 to 3% of the cases. It is more associated with the sarcomatoid histology, and it is also done by NGS technique. Can you go to next slide? Then RET pathway is RET. We see rearrangements by amplification. It is found in 1 to 2% of the lung cancers, and it is there are multiple targets available, and we do mostly by DNA NGS, RNA NGS. Can you go to next slide? So MET also better technique is DNA NGS. We discussed that. Next slide. Now we have NTRK fusion, which is also very rare, found, very rarely found. Actually, it has been seen in umbrella trial that we have a drugs available for that pathway, and we're getting better results. So this pathway also has is seen by NGS, but we can also do this screening by ISC. If ISC is positive, then we can go for NGS. Next, we discussed that slide. Can you go to next? And HER2, we have to see here, there are two things: HER2 overexpression, HER2 mutation. So HER2 overexpression can be because of mutation or because of amplification. In lung cancer, we see mutation only, and that to exon 20 mutation, because the drugs available are only for these mutations, and they are only seen by NGS. Next. So this is the slide which we this is the path way of using multiple drugs, which we will discuss in the next presentations. And then PD-L1 expression. This is applicable in those cancers. This is these we apply in those we are non-driver driven. So we have antibody and we have particular platform for that. One of the platforms is DACO, another is Ventana. Ventana we have two. One is SP. We have in Ventana we have also two paths, 143 and. Can we go to next slide? Actually, this slide is slightly. So we have a scoring system which we use for immunotherapy. One is TPS, another is CPS score, then IC score, and we see the percentage PD-L1. So every immunotherapy has a particular companion test, which we have to do to see the activity of the drug. For pembrolizumab, we use DACO as a platform, and we do test. Similarly, atezolizumab, we use Ventana SP142 for the for a metastatic setting, and we use SP143 if we use as in the first line setting. So we have to always devise which platform we have to use for a particular immunotherapy and particular protocol. Next. So these are the different antibodies used for different PD-L1 testing. And one thing, PD-L1 testing is not done by NGS, it is always done by ISC. Next. So what can we say that PD-L1 is a sole current biomolecule able to guide immunotherapy. It is another thing is TMB, which is conflicted in the lung. MSI and MMR has no role in the lung cancer. And LAG3 pathway, which has been shown to resistant to immunotherapy, is controversial. Next. So biomarker lung testing is always controversial. It is multiplex testing. It is and it always needs a multidisciplinary approach. And for solid tumors, content tumor should be 1 to 10% to prevent delaying of the process. Ideal testing is 2 weeks, and NGS is always considered best platform compared to other techniques. Next. So thank you.
Thanks a lot, Dr. Saqib, for this wonderful presentation. So this was a well-discussed and in-depth presentation, and I'm sure all of us got to learn so many things about biomarker testing, because obviously it's a controversial topic and practices vary in the country with different oncologists practicing differently. Just one thing I want to ask you, when a fresh patient comes to you presenting with lung mass and let's say liver metastasis or a supraclavicular lymph node, so what is your ideal site for biopsy? Do you go for easily accessible metastatic site, or you go for the primary lung site, which might be technically challenging to approach by CT guidance or by bronchoscopy guidance?
Sir, am I audible? Can you listen to
Yeah,
me?
yeah,
So,
Dr.
first,
Sakib.
any patient of lung cancer, one will have an imaging suggestion of primary lung mass within metastasis anywhere. So, easy accessible size is always preferred because
Mhm.
we see that these patients are PS2 or PS3, and we have got better ISC value. So, easy. First thing is we should always prefer a biopsy from easy accessible site.
Right. I agree. And second thing is, well, when you're ordering for NGS, in the NGS panel also there are variety of panels available in market these days by different companies. So some are offering just EGFR, Alcross. Now most of them have expanded to include the BRAF, HER2, and NTRK also. But at least, so do you prefer the focus hotspot mutation NGS panel, or do you go for comprehensive genomic profiling?
So, what is my practice is that first,
Yeah. Exactly. That's what I was
first
about.
it depends on the amount of tissue we have. So obviously, at
Mhm.
this point of time we have a better interventional radiology team, so we don't have to worry further tissue. Second thing is the patient finances. So that is most important. So at this point of time, we have many companies providing 12 gene lung panel, which we prefer. Third thing is that going for an extensive mutations is more of academic rather than the clinical sense because we don't have drugs available for each and every mutation. So we keep it short, we keep it limited. We go for 12 gene lung panel at this point of time, which we discussed, rather than go for 55 genes or hotspot. This see at this point of we know that if we get a p53 mutation in a patient who is EGFR positive, we know that he will rapidly
Absolutely.
progress. We
That's
have a
what I was
data for
coming forward because now there are data getting
we have a
generated
data
that these are
for
resistant to
every.
EGFR.
So we have to make it simpler rather than making it complex. And we have to. And second thing is the financial patient, which always is a in the loophole. See, we have many patients still at this point of time who don't afford oximetry. We have got good chunk of patients who are still on second generation or first generation TKIs. So we have to think each and every context. So it depends on patient to patient.
Definitely. So thank you so much, Dr. Sakib. So I think I would like to move ahead with our next presentation. So I would like to invite Dr. Anshul Gupta, who is an associate consultant in Max Institute of Cancer Care, Vaishali, and Max Institute of Cancer Care, Noida also. You will be talking about overview of lung cancer in general. Welcome, Dr. Anshul. Over to you, sir.
Thank you, Dr. Kapil, for inviting me. And it's always a pleasure to be amongst you. So let me just quickly share my screen. Allow me a moment. Just a second, please. Okay, so I'll be sharing my screen. Perfect. Slides are visible, I presume. Slides are visible?
Yes, sir, they are
Yes, sir,
visible.
it's
You can
visible.
start.
Yes, sir, you are
Perfect.
visible, sir. Please go ahead,
Perfect.
sir.
Okay. So I'll be speaking about overview of lung cancer. And to start with, let's talk about the burden of lung cancer in India as per the Globocon 2020. So if you see up here, lung cancer, the number of new cases, that is the incidence, was 5.5%, in both sexes combined, all ages combined in India. And number of new cases in 2020 in terms of males, it comprises of 8% of the total cancer cases. So it is the second most common cancer in males after head and neck cancers. So, well, the first thing for any cancer to be treated, it has to be optimally staged, and that only, paves the way for the best course of therapeutics. So, there are a few changes in AGCC 8th edition as compared to the AGCC 7th edition. So, if you see T2B, uh, which was more than 5 centimeter but less than 7 centimeters, and if it had N1, T2B N1, it was stage 2B. And if T3 with N0, it was also stage 2B. But now here, uh, it is T3, which is 5 to 7 centimeters, but T3 5 to 7 centimeter along with N1 as per HACC 8 is 3A and not 2B. Likewise, uh, T4, which is more than 7 centimeter, if it is with N0, it is stage 3A. So these are the few changes. So of course, to investigate, we have a few tools at our disposal. So bronchoscopy, CCT chest, PET-CT, EBUS or endoscopic ultrasound, mediastinoscopy, and MRI brain are often the investigations that we use at the baseline to establish the stage of the lung cancer. So, a word about the role of CECT versus PET-CT for staging of stage 3 NSCLC. So, the lymph nodes, which are more than 10 mm in along the short axis, they are predictor of malignancy. So, CT scan, if done alone, has a low sensitivity and a low specificity of 55 and 81% respectively. However, it may help in selecting appropriate procedure for tissue sampling by providing the images. The addition of PET-CT increases this overall sensitivity from 55% to 80 to 90%, and again the sensitivity from 80% to close to 90 to 95%. So hence, nowadays PET-CT is the investigative modality of choice when it comes to specifically locally advanced NSCLC. So, uh, what are the occult risk factors for occult N2? So if it is a centrally located tumor, then definitely. If SUV max is more than 4.0, then, and if the tumor size is more than 6 centimeter, so these are usually the factors which, even if we do not have an occult or a overt N2 disease on the PET scan, then we should always try to look for it in the presence of these, because there is a very high possibility in such situations. So mediastinum staging can be done by two ways. Something which is less invasive, which is a EBUS or a biopsy by EBUS TBNA or EBUS biopsy, and invasive mediastinoscopy, which can be done by a conventional method or by WATS method. So mediastinal staging. So again, as we said, recommended technique is EBUS and EUS. If there is a clinical suspicion of N2 involvement, which remains high even after a negative EBUS or EUS, then surgical staging with mediastinoscopy is the salvage option that we can do if the suspicion is really high. So when is again invasive mediastinal staging indicated? If tumor is centrally located, tumor is more than 3 centimeter, if there is an extensive infiltration of the mediastinum with no evidence of extrathoracic disease, or there is a positive N1. Bulky N2 on CT, there is no need for invasive confirmation as it is already taken to be positive. If there is discrete N2, yes, regardless of the PET-CT result, again it is taken to be positive. So normal mediastinum on CT, but positive on PET, yes, it is taken as positive. However, if there is a normal mediastinum on CT and PET, then it is usually considered as a negative N2 or node positive. So this is the mediastinal staging algorithm. So PET-CT with the intrathoracic lung cancer with or without enlarged lymph nodes. If mediastinal lymph nodes are negative, then we see if clinically it is N0 and there is low probability of unforeseen N2 disease after negative PET-CT, that is less than 3 centimeter tumor or peripherally located tumor, then we directly go for surgery or radical radiotherapy, whatever is the treatment of choice in that particular patient. If it is CN1 or N0 and there is a high probability of unforeseen N2, then we do tissue confirmation by EBUS or EUS. Again, if the mediastinal lymph nodes are negative after this procedure, we proceed with the surgery, and if they are positive, then they again get upstaged and the multimodality treatment kicks in. However, if at the baseline only the PET-CTs, the mediastinal lymph nodes are positive, if there are mass or bulky lymph nodes, then no tissue confirmation is required and it is considered to be positive, and then we straight away proceed to the multimodality treatment. However, if they are non-bulky lymph nodes, then again the method of confirmation is EBUS or EUS, and we follow the same protocol. If it is positive, then we proceed to multimodality treatment. If it is negative, then again we can go for, since these are high risk patients who have already mediastinal lymph nodes positivity, and we want to rule out tissue positivity in such situations, then we may go for a surgical staging or a mediastinoscopy in such patients. So if you see, these are the different mediastinal lymph node stations, and these are the methods by which they have these are the mediastinal stations which are positive on these with these particular techniques. I'm not going to go into the details of these. So, non-invasive and invasive staging modalities. If you see the sensitivity, as we go from CT 55, PET CT 80 to 85, EBUS it increases further, and all the way close to 100% with the use of VATS. So, this was about the imaging part of it, or the baseline investigations. Now we talk about the evolution of therapy in lung cancer. So again, as NSCLC, which was once considered as a single disease, is now considered as a plethora or a basket of different diseases which are clubbed together under the umbrella of NSCLC. And the subtype characteristics are clinically relevant for treatment planning and diagnosis, as we know now that the it is a heterogeneous group, and the treatment part, it varies from each subtype. So, as we go from here, this is the complete umbrella of lung cancer. It includes small cell lung cancer, which have a different morphology, treatment, and prognosis. And then there is this NSCLC. Again, this histological breakdown of NSCLC can also be uh, large cell adenocarcinoma, SQ, non-SQ. Then molecular pathology wise, we have n number of mutations, EGFR, L cross, to name a few, BRAF, NTRK, RET, and others. And then again, for the ones which do not have any driver mutations, PDL1 expression is again leads to the heterogeneity. It could be either more than 50%, less than 1%, or 1 to 49%. And lastly, they can be classified as per the tumor mutation burden of less than or more than 10 mutations per megabyte. So, uh, to talk about advances in the management of NSCLC, if you see the lung cancer survival, it has improved from 26% amongst men with NSCLC that was diagnosed in 2001 to 35% in those who have been diagnosed in 2014. So there is often reduction in the incidence along with treatment advances, particularly the targeted therapies. And I think that's the wonderful paradigm shift that has taken place in the NSCLC with targeted therapies coming along. The overall survival in the PFS is continuously increasing. Talking about the targeted therapy and immunotherapy, if you see, this is a historical chart which tells us 2006 chemotherapy with bevacizumab was approved for NSCLC. In 2009, platinum with pemetrexed for NSCLC was approved. And coming to the second decade of the 21st century, crizotinib, erlotinib, gefitinib, again ceritinib, dabrafenib, alectinib, osimertinib came in 2018 and was a game changer. And now we have the NTRK inhibitors, entrectinib and larotrectinib, and then MET positive and red positive, capmatinib, selpercatinib, and brigatinib for L positive, with lorlatinib being the recent one in these in the series. And of course, the immunotherapy, pembrolizumab, pembro plus chemo, atezolizumab, nivo-IP combination is now approved, and latest semiplimab has also come in the lung cancer immunotherapy arena. So, talking about the molecular targets, so all patients in NSCLC should undergo a molecular profiling to identify targetable mutations. And as we saw in the last talk, we can use either of the strategy, either the hotspot one or a comprehensive genomic profiling. So, but if you're using a hotspot one, then at least KRAS, EGFR, AL cross, RET, NTRK, HER2, BRAF, PIK3, all RAS, AKT, MET, and MAP are these are the mutations which should always be covered. So, molecular targeted therapies are available across for targeting EGFR, L cross, BRAF, and TRK, MET, RET. Now, KRAS is also sotorasib is also approved for the same indication. So, this is targeted therapy in the metastatic setting. So, current guidelines on neoadjuvant and adjuvant chemotherapy depend upon the stage and the finding during surgery. So, stage 1A, if there is observation is good enough, stage 1B or 2A, MDT for adjuvant chemotherapy for high risk patients. Stage 2B onwards, of course, adjuvant therapy is recommended. and stage 3A or 3B. So there are multiple therapies, multiple options that can be the neoadjuvant chemotherapy, adjuvant, or sequential chemo followed by radiation for N2 disease. So findings at the surgery and surgical resection margins also affect adjuvant treatment. If it is R0, then obviously, for stage 1 or 2A, no treatment is recommended. For 1B, it is chemotherapy, and for 3A or 3B, it is CTRT. However, for R1 or R2 margin, R2 surgery, then re-resection is preferred for stage 1 or 2A, for 2B re-resection plus chemotherapy, and CTRT for stage 3A or 3B tumors. So after initial treatment, more than half of the patients with resectable NSCLC, they experience a recurrence within the 5 years. So yes, that is a big challenge, and we need to do more and more. We need to bulk up the therapies to ensure that the number of recurrences are lesser and lesser. So the latest ESMO guidelines recommend that the adjuvant therapy can be considered in patients with resected stage 1B and who have a primary tumor of more than 4 centimeter due to clear evidence of benefit. You can see these curves, pardon me, separating out here. So this is the LACE meta-analysis, I think, which established the role of adjuvant chemotherapy along with cisplatin and vinorelbine being the most commonly used agent, and they've improved overall survival with an absolute benefit of 3.9% and 5.4% and 3 and 5 years respectively, with a hazard ratio of 0.89. And this laid the foundation for the addition of uh, cytotoxic chemotherapy as the adjuvant. So, neoadjuvant chemotherapy, if you see, for stage 1B to 3A, the neoadjuvant chemo, the hazard ratio is 0.87, and for adjuvant, it is 0.89. So, again, it is relatively debatable. Now, coming to the part that ADAURA trial, it has improved DFS with osimertinib in resected EGFR mutated NSCLC, and you can see it is a brilliant game changer with a hazard ratio of zero point 0.2, which is amazing. And you can see these curves, they start separating initially and they don't meet ever after. So this has been now the standard of care in adjuvant EGFR mutated resected lung cancer. Atezolizumab has also shown an improvement in DFS as well as OS in the adjuvant setting. So again, a word about the radiation advancements. So IMRT has been shown to improve survival in patients with stage 3 and T3, T4 tumor. It reduces the rows to heart and decreases pneumonitis. And it also increasing dose to heart is associated with higher risk of death in stage 3 NSCLC. Such things are avoided with IMRT and better radiation techniques. So I'll skip this slide. So lung cancer radiation in 22, 4D CT planning is there, IGRT is there, adaptive radiation, and end result is the smaller target volume with lower doses to normal tissues. Contemporary RT techniques in stage 3 NSCLC, if you see the long-term results of RTOG 0617 trial, you see even with a lesser dose, the 5-year OS is better with better techniques. So chemotherapy, with or without radiation, is the standard of care after complete resection in stage 3 NSCLC. I think we have discussed this previously, this slide. So now checkpoint inhibition is moving to early stages. Of course, the Pacific trial, it is a randomized double-blinded placebo controlled phase 3 trial of consolidation durvalumab in unresectable NSCLC. And if you see that, the curves have separated and in stage 3, and this is now pretty much the standard of care. So it has demonstrated 42.9% overall survival at 5 years as compared to historical OS in unresectable NSCLC stage 3, which is 15 to 25%. So although there is no direct head-to-head comparison, but still it is a very encouraging figure, and now it is a pretty much the standard of care. So a word about the emerging treatment paradigms. Of course, immunotherapy and targeted therapy are the therapies which are there finding a place in almost all the cancers, and NSCLC is the one in which they started. So Flora trial, it gave us osimertinib versus the first generation EGFR TKI, and it strongly established osimertinib as the standard of care in EGFR mutated advanced NSCLC. Uh, and Alex trial, it gave us alectinib versus crizotinib in advanced ALK positive NSCLC. So both with chemotherapy, the median PFS is 5 to 7 months. With EGFR TKI, it is now increased to 18.9 months, and ELK, it has increased to 34.8 months, which is even further on the rise as we speak, as we have more and more drugs. So, other emerging molecular targets, MET exon 14, alteration or MET amplification, we have crizotinib active against it, RET rearrangements, we have cabozantinib and danatinib, NTRK, we have larotrectinib and entrectinib, and HER2 mutations, we have enotrastuzumab. So, with recent advances, survival rates are improved, and as you can see, it is going up to 44 months with larotrectinib. Alectinib, it has not reached. Even even lorlatinib, it has not reached. So we are seeing an era in which the PFS and the overall survival are continuously increasing in the era of this targeted therapy. Now, talking about the immunotherapy, of course, there are so many active immunotherapy agents, CTLA4 and PDL1 blockade being the major mechanism of action. So, immune checkpoint inhibition, as pembrolizumab was approved in 2015, then moving on to atezolizumab and nivo-ipi combination in 2020, and the latest one being cemiplimab. So, again, historically, if you see, if you see the fact that chemotherapy had a median overall survival of close to 12 months, but with now immune checkpoint inhibitors, we are seeing overall survivals of 2.5 years, which is very much encouraging. So this is the same thing that I was saying in terms of graphical representation, that the median OS is 26.3 months vis-a-vis 13.4 months, and it showed almost doubling of that. So it is also moving to stage 1 to 3 Pulse or the Keynote 091 trial. Pembrolizumab, it established the role of perioperative pembrolizumab in in NSCLC. And then, of course, ADCs are the ADCs and CAR-T are the new era molecules that we will be looking for. So key takeaway is the management of NSCLC is fast changing, and we have to change ourselves and keep ourselves updated. Neotherapies, they have a huge potential, and they are leading to increased overall survival across various subtypes. Oral pills have actually lessened the burden of the patients, and pulmonologists will play a huge role in early diagnosis, and health crucial to involve them in the NSCLC tumor boards. With that, I thank you, and I'll be happy to answer any questions. Over to you, Dr. Kapil.
Yeah. So if there's any question, so Dr. Anshul, thank you so much for the engaging talk, and I'm sure this was very well taken, and we all learned a lot from this talk, and we got an overview of how the lung cancer are diagnosed and managed, and
Can I
this
ask
new
one
advent of
question? Just one question.
Yeah.
Not
Please go
Saket.
ahead, Dr.
So
Saket.
I have one query. That if in many of our scenarios we have patient who does CT chest and abdomen, we have a liver mets. We are already stage 4 diagnosis on CT. Do we need to do in them also PET scan? We know MRI is to be done in every patient of lung cancer. So if we are already a metastatic disease on CT, should we do MRI? Should we do PET at that time or not? That is the only thing I am always confused. There's a big tussle on that. So I want to see what your practices are for the patient.
So, sir, in this situation, if the abdominal section they cover adrenals, and if the adrenals are fairly covered, then we can do a PET scan. Okay. And sorry, we can do with the CT scan only, and we need not do a PET scan. But we have to see that what would be the serial modality with which we would be comparing. It is always better to do a modality with which you will compare it in the next time. So a CT versus PET comparison is, approximate at best. It is not a very good comparison. However, the practice what we and Dr. Kapil and Dr. Rakesh we used to do at AIMS was that if the CT involved adrenals, then it is good enough for us. Then we don't need to do a PET scan if it is already stage 4 metastatic.
Sir.
So I think I also agree with Dr. Anshul. So usually it is recommended that in the localized cancer, it is recommended the CT scan be included only till the upper sections of abdomen so that the arterials are included. And once CT scan is good enough modality for seeing the liver, the adrenal, and the bone also. MRI, however, has to be done in each case, starting even in the early locally advanced cases as well in the advanced stage. So MRI brain has to be done separately apart from the CT scan. So that is given. So are there any more questions? So thank you, Dr. Anshul. So moving ahead, I would now
Pleasure.
like to invite Dr. Yeah, I would now like to invite Dr. Rakesh Sharma, who is an associate consultant of medical oncology in Max Cancer Hospital, Sake. Dr. Rakesh will be talking about decoding treatment options for EGFR mutated NSCLC. Over to you, Dr. Rakesh.
Thank you, Dr. Kapil. So, in the interest of time, I will be skipping the slides already covered in previous talks. So, I will straight away move ahead. The parameters, as Dr. Kapil has already mentioned, that I will be discussing on the EGFR mutated lung cancer. So, what are the factors determining the choice of first-line treatment in EGFR mutated NSCLCs? So, the major driving factors are the PFS benefit, OS, ORR, presence of brain metastasis, safety, quality of life, and availability of subsequent lines of therapy. So, now, as everybody is aware, osimertinib has been approved as first-line treatment for metastatic and EGFR mutated NSCLCs that has demonstrated best PFS as well as OS, that is 18.9 months of PFS as compared to other like dacometinib 14.7 months, afatinib 11 months, lotinib around 11 to 13 months. There was a range in various trials, and similarly gefitinib around 10 months. So this is the Kaplan-Meier curves comparing outcome with second generation TKIs like afatinib, dacometinib, and third generation TKI like osimertinib. So as we can see that in Lux Lung 7 trial, afatinib was compared to gefitinib, in which patients, about 16% of the patients have stable brain metastasis, and the separation of the curve was not that great. And even the curve separated very late in the follow-up time. Similarly, in dacometinib, the separation of curve was also late. However, there was significantly better PFS with dacometinib as compared to gefitinib. However, in FLORA trial, there was immediate separation of curve, better overall response rate, and better PFS and obviously overall survival. And there were around 19% of the patients with stable brain metastasis in FLORA trial. So if we look at the response rates, so in Lux Lung trial, the response rate with afatinib was around 70%, gefitinib was around 56%. In Archer trial, the responses with dacometinib were around 75% and 72% with gefitinib. In osimertinib trial, the response rates were highest, reported to be 80% as compared to gefitinib, in which it was 76%. Overall survival reported to be around 38.6 months with osimertinib, whereas in comparator arm it was 31.8 months. In Lux Lung trial, the survival benefit was there numerically, but it was not statistically significant. However, dacometinib had overall survival of 34.1 months versus gefitinib 27 months. It was statistically significant. However, it is less as compared to osimertinib, although it is a cross-trial comparison. There is no head-to-head trial comparing osimertinib with dacometinib. So we can see that in osimertinib trial, about 28% patients were continued to receive osimertinib at 3-year data cutoff. So we can see that patients with patients on osimertinib tend to survive longer, and there are better chances that patients will continue to have therapy even beyond 3 years of follow-up. So if we compare patients with brain metastasis, without brain metastasis, obviously patients without brain metastasis will do better as compared to patients with CNS metastasis, and survival will also be better in patients without CNS metastasis. So PFS in patients with CNS metastasis was 15.2 months versus 9.6 months in standard of care arm. Similarly, it was significantly better in patients without CNS metastasis, being 19.1 months versus 10.9 months. And CNS progression events were lower in osimertinib arm, being 6% versus 15% in patients with standard of care arm. So intracranial PFS was better with osimertinib as compared to standard of care. CNS progression is also lower as compared to other TKIs. So this I have already highlighted. Patients on osimertinib tend to have better PFS as well as overall survival as well as lower CNS progression rate as compared to other TKIs. So looking about a bit about the safety. So grade 3-4 events reported with dacometinib were around 63% in Archer trial, with afatinib around 31%, and with osimertinib 18%. So we can see that osimertinib is also better tolerated as compared to other TKI in terms of toxicity, being grade 3 or 4. The majority of patients with dacometinib have skin toxicity, whereas with afatinib, diarrhea was more common. And dose reduction in EGFR TKIs. So in Lux Lung trial, there were about 42% dose reduction required with afatinib. In Archer trial, 67% patients required dose reduction with dacometinib. However, dose reduction was more or less similar with osimertinib and standard of care being 5% and 4%. So we can see that osimertinib is better tolerated, requires less dose reduction as compared to other TKI, second generation TKI like dacometinib and afatinib, and of course better overall response rate, PFS and OS. And quality of life was also better with osimertinib, although quality of life was maintained and bit improved with afatinib, but considering dosage reduction, overall survival, PFS, CNS benefit, I would prefer to start patients with osimertinib. And 1/3 of patients who were started on and second generation TKIs, only 1/3 of the patient receive osimertinib. So it is best to start osimertinib in first line, as the frequency of T790M mutation is around 40% with first or second line generation TKI. 30 to 40%. So only 1/3 of the patient will eventually receive osimertinib. So real world evidence of T790M mutation after afatinib is approximately 32 to 48% reported across various studies. So sequencing of EGFR TKIs, although this was a debate in this was to be a common debate, but nowadays it is well established that osimertinib should be the first line treatment irrespective of the type of mutation, being EGFR exon 19 or be it exon 21. So osimertinib should be the first line treatment. We are As we cannot predict which patient will develop T790M mutation. And even if we start patients on first or second generation TKI, only 30% of the patients will receive osimertinib in second line, subsequent lines of therapy. So factors determining sequencing is the toxicity, T790M mutation, sites of progression, other morbidities, and patient's choice. So real world data, this is the flower study in which the median PFS was around 20 months with sorry, in this median time to disease progression was around 18.8 months, and which is more or less similar to Flora trial, in which the median PFS was around 18.9 months. Response rates were also similar in this study. Similarly, OCFACT study also demonstrated a median PFS of around 20.5 months and overall response rate of 76.1%, which are in concordance with the trial data. There was one highlight in OCFACT study in which grade 3 pneumonitis, which was reported in 12.8%. This is not reported, this was not reported in the Flora trial. So this is the very high frequency as compared to the trial. This needs further evaluation. Although the PFS data and response rate were similar, but pneumonitis rate was pretty high. So this needs further evaluation. In NCCN guidelines, patients with exon 19 or exon 21 mutation, preferred first-line agent is osimertinib. Other recommended agents are first generation and second generation TKI, or combination of first generation TKI with either chemotherapy, ramucirumab, or bevacizumab. So there is no doubt about the first-line management of metastatic NSCLC. Osimertinib should be the first choice. Now we have combination data of osimertinib with chemotherapy coming up in Flora 2 trial, which has demonstrated better PFS as compared to the osimertinib alone, although the OS data is still pending. I think that will change the management of metastatic NSCLC, particularly in young fit patients, in which we can allow the combination of osimertinib with chemotherapy. So osimertinib should be the first line treatment in metastatic NSCLC, which has demonstrated best PFS and OS rate, and it has also better CNS penetration, lesser CNS progression rate, better overall and overall survival and PFS in patients with brain metastasis. And this is the only TKI active against T790M mutation. So with this, I conclude my talk. I thank Dr. Kapil to provide me this opportunity. I will be happy to answer the questions if there are any.
Thank you, Dr. Rakesh, for this wonderful presentation. I'm sure we got to learn a lot about the management of EGFR mutated TKI. So I wanted to discuss a very important thing. So now I'm sure you are aware that Flora 2 trial has been published, and it has shown that the combination of osimertinib and chemotherapy has shown superior PFS compared to osimertinib alone. So with that data, although the OS data is not mature and it has not shown much OS benefit so far, although the median OS we still do not have that data. So in that light, suppose as of today, a patient comes to you. So has it changed your practice? Are you still giving osimertinib alone as it has not shown any OS benefit, or has your practice changed to accommodate chemotherapy along with osimertinib as of speaking in November 2023?
So if we take that data into consideration, I am offering osimertinib with chemotherapy in young fit patients only, as most of the patients do present in poor performance status state. So majority of the patient will end up getting osimertinib alone, but patients in young patients with ECOG PS of 0 or 1, I think with the PFS data only we can offer osimertinib with chemotherapy, although I would like to wait for the OS data. But majority of the patient in second line tend to have poor performance status. So if you have to hit hard in the first line only, I think osimertinib and chemotherapy should be the standard. Given
So,
that,
in a nutshell, you base your decision based upon the performance status and the age profile of the patient, right?
yes, I think I have answered that question.
Okay, so
I
Dr.
have one.
Rakesh, we have another question from Dr. Kamal in the chat box. So he's asking how many cycles of chemotherapy to be given with osimertinib. Would you like to take that question?
I think 4 to 6 cycle depending on the tolerance and side effect profile.
So I think I usually give I mean, now I have changed my practice. And osimertinib, I'm giving chemotherapy unless patient is old enough so that they cannot tolerate chemotherapy. So 4 cycles of pemetrexed and carboplatin. 4 cycle we are giving, but after that, what about the pemetrexed maintenance also?
No, I think in maintenance only osimertinib is enough.
Osimertinib. So if you are giving pemetrexed and carboplatin, so you are restricting yourself to 6 cycles or 4 to 6 cycles, and then you do not use pemetrexed in the maintenance as was the trial design, right?
I'm yet to use that combination. Till now, I have used osimertinib only, but
Mm-hmm.
and
Okay, so I think we need to check completely exact trial design of Flora 2, and accordingly we can take a call. And moreover, we need to wait for the OS data maturity also, right?
I have actually one question. Can I ask?
yeah, please.
Okay. Sorry, I bothered you with the questions. So actually, today I was in the OPD. A patient came to me. She is almost 70 plus, case of metastatic adenocarcinoma lung. She was EGFR 21 L85R point mutation positive as well as exon 18 positive. So she was started by outside oncology by erlotinib initially. She responded to 6 months. Then she was shifted to afatinib. Now she came to our center, Paras center, with progressive brain mets. So what should I do with that patient? Any experience of that? Or you have exon 21 plus exon 18 mutation positive. That outside oncologist also has done liquid biopsy to see for T790 mutation. It is not there.
Okay. But I think in subsequent line of although osimertinib in second line is approved in T790M mutation, I don't know why we cannot use in other mutations, because in first line we don't even test for any resistant mutation and we straight away start osimertinib. But in second line it is just restricted to T790M mutation, because of the trial design. But I think we can offer osimertinib. I think I have asked this question across many platform and there is no answer to this. Why not in other mutation if there
So
is
in
no?
exon
I think the
18,
thing
we
is
can.
that anyway, the such patients are very rare, presenting with T790M mutation in upfront. These are very rarity, I think.
No. Oh yeah, that I agree. But in second
And
line,
exon 18?
40% will have T790M mutation, but 60% will not have. So why, and first line you have used erlotinib or gefitinib. So why don't we give the benefit of osimertinib in second line in patients without T790M mutation?
Mm-hmm. Agreed.
I think there is no answer to this question because there is no trial and only retrospective or case series will be there. But
Agreed. Agreed.
Dr.
So is
Rakesh,
there
can
any other
I
panelist?
yeah, can I also ask one question to Dr. Rakesh?
yes, Shalabh,
Uh,
please.
So, what is your preferred drug for uncommon EGFR mutations? Like just yesterday, I got one patient with G719Q. So would you start with the second line or would you straight go to osimertinib? I know there's no data in either of, I mean, there's no good data in either of you with either of these. So what's
Yes,
your approach?
I think osimertinib.
So I think afatinib is the practice. So for uncommon mutation, most of the uncommon mutation, afatinib has been found to be more
Patinib has
suitable.
good response, but I think osimertinib should be preferred.
Any difference in practice of exon 19 versus exon 21? Like we have a data of using this erlotinib plus ramucirumab versus osimertinib. So any change, any other difference in institutional practice that some use for exon 21 osimertinib, and for exon 19 we use this
I think
erlotinib
they're
plus.
pretty much same. I think they're pretty much same.
It should be
So
osimertinib. Apart
so
from exon 20,
what is
second,
your all of you use this osimertinib?
yes. Apart
Okay.
from exon 20, other mutation, it should be osimertinib. There are some mutation in which afatinib is effective and in some dacometinib is effective. But the side effect profile of dacometinib and afatinib is worse as
Exactly.
compared.
Afatinib is a very difficult drug to give. So I put just 2 patients on afatinib and the side effect they could not tolerate. So
So
that is one big
osimertinib
problem.
is better
Osimertinib, while on the
tolerated.
other hand, is very well tolerated.
Yes, osimertinib is better tolerated, better overall response rate, survival data is better as compared to other TKIs. So it should be the first line treatment.
Mhm. Right. Anyway, I think now the new practice is to have a molecular board in house, and then we can, the molecular biologist and the pathologist, they will sit together and with the molecular, because new data are coming up like mutation like P53, which can render the tumor resistant to EGFR inhibitors. So I think such difficult and rare cases should be discussed in molecular board, and then a combined decision can be taken.
I think in future patients will be managed as per the mutation, not per the site or morphology.
Definitely. So, are there any other question for Dr. Rakesh? Thank you, Dr. Rakesh. So thank you for the wonderful discussion, wonderful talk, and we had a lively discussion with you. So next, moving ahead. So next, I will be giving one presentation on early lung cancer, in which I will be talking mainly about the ADORA trial, so which is the adjuvant osimertinib data that I will be sharing. So I hope my slides are visible and I'm audible.
Yes,
Yeah.
sir, your slides are visible and you are
Okay,
audible.
okay. Thank you. Thank you so much. So, osimertinib in early EGFR mutated NSCLC patient. So, for a brief review, we know that lung cancer is the leading cause of cancer death, and it accounts for more than 1.7 million deaths annually. That is the global data, and as many deaths as breast, prostate, and colorectal cancer combined. So, it is number one cause of death, actually, globally speaking, and it represents 85% of all lung cancer cases. The NSCLC, rest 10 to 15% are small cell carcinoma, with an estimated 30% of the patient presenting with resectable disease at diagnosis. So 30% data I feel is talking globally. In India, we do not see that many patients who are resectable at diagnosis. So I think various oncologist practices vary, but I think they should be somewhere between 10 to 15% only. So classically, we categorize them with the localized early stage, that is up to stage 1B. So that is the lung tumor up to 3 to 4 centimeter. And then we have regional or locally advanced, that is stage 2 and stage 3A tumors, in which the 2 and 2 nodes are involved. Yeah. So far the outcomes in early stage NSCLC have not been very great, and surgery is the primary treatment for such patients. And adjuvant cisplatin-based chemotherapy has been recommended for patients with resected stage 2 to stage 3A NSCLC, and select patient with stage 1B disease. So we had a large randomized trial and meta-analysis which showed that the 5-year OS benefit with adjuvant chemotherapy in patient with early stage NSCLC, the hazard ratio was 0.89, and DFS also favored adjuvant chemotherapy. Then we had the LACE meta-analysis, in which the benefit of adding adjuvant chemotherapy in such cases were clearly highlighted. Overall, the disease recurrence or death following surgery and adjuvant chemotherapy still remains high, because the high uh, across whatever disease stage that you take. So 5-year recurrence rate according to the stage, it is 76% stage 3, 62% stage 2, and 45% stage 1. So even if you catch the patient in early stage, that is stage 1, is still 50% of the patient would recur within next 5 years. A second. Yeah. So based on limited number of studies, the prevalence of EGFR mutation appear broadly similar across the disease stage, and the Asians have high prevalence of EGFR mutation, that is 30 to 40%, while it is lower in the Caucasian population. If we take it according to the stage 1, 2, 3, 4 in the Asian population, mainly I will be focusing. So approximately in all the stages, approximately 1/3 of the patient have EGFR mutation positivity, while it is approximately 20% in US and even less, 10% in the Europe. So if EGFR TKIs were available in the resectable setting, a similar portion of the patient may be able to benefit compared to the advanced setting. So keeping those points in mind, so ADORA trial was designed, which is osimertinib as adjuvant therapy in patient with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. So it was a phase 3 double-blind study in which patients who had undergone complete resection of stage 1B to 2 to 3A NSCLC with or without adjuvant chemotherapy. To be taken in mind, here the stage 1B was taken as the 7th edition of AJCC. Then the key inclusion criteria were more than 18 years of the patient with WHO performance status of 0 and 1, confirmed primary non-squamous NSCLC with exon 19 deletion or L858R mutation, brain imaging if not completed preoperatively, complete resection with negative margin, and maximum interval between surgery and randomization was 10 weeks without adjuvant chemotherapy and placebo arm 26 weeks with adjuvant chemotherapy. They were stratified according to the stage, EGFR mutation, the kind of mutation, and race, in randomized in two arms. One was osimertinib 80 mg per day, that was the one arm, and the placebo once daily. So plant disease treatment duration was 3 years, and the treatment continues until the disease recurrence, treatment completed, or discontinuation criteria were met. Follow-up was done until recurrence, week 12 and week 24, and then every 24 weeks up to 5 years, and then yearly. After recurrence, every 24 weeks for 5 years, and then yearly. The endpoints were primary endpoint were disease-free survival by investigator assessment, and secondary endpoint were DFS in the overall population, and DFS at 2, 3, 4, and 5 years. Apart from this, overall survival, safety of osimertinib, and health-related quality of life with other secondary endpoint. So inclusion and exclusion criteria. So inclusion criteria, as I've already mentioned, the adult more than 18 years of age, primary non-squamous NSCLC, and post-operatively stage 1B to 3A. So centrally confirmed mutation EGFR exon 19 deletion or L858R mutation. Standard post-operative adjuvant chemotherapy consisting of platinum-based doublet for 4 cycle maximum is allowed but not mandatory. Complete surgical resection of primary NSCLC and recovery from resection surgery. Treatment to start no earlier than 4 weeks following surgery. MRI or CT scan has to be done prior to surgery, and WHO performance status 0 to 1. So patients who had received pre or post-operative radiotherapy were excluded. Pre-operative chemotherapy were excluded. EGFR TKIs who had received any form were excluded, and any CYP3A4 inhibitors. And time between surgery and randomization not more than 10 weeks. And patients who had only segmentectomy or wedge resection were also not taken. Cardiac criteria, including factors that could increase the risk of QTC prolongation or any arrhythmic events, were also excluded. Any evidence of severe or uncontrolled systemic disease and medical history of ILD or any other malignancies were also excluded. If we look at the baseline characteristic of both the group, we see that both are very well managed. 68% patients in both the arms were female and only 30% patients were male. Median age was 64 years and 62 years. Most of the patients were non-smoker and only 1/3 patients were smoker. 65% patients in both the arms were Asian. And stage wise, if we see at the diagnosis, the stage approximately 1/3, 1/3, 1/3 were stage 1B, stage 2, and stage 3A. Histology, almost all of the patients were adenocarcinoma with some few rare histology, and EGFR mutation were equally divided between exon 19 deletion and L858R mutation. Adjuvant chemotherapy, 60% patient received adjuvant chemotherapy, while 40% patient did not receive any chemotherapy because of the physician discretion. So here's the Kaplan-Meier survival curve. If we see the DFS, the curves are beautifully separated, while the yellow line representing the placebo arm and blue line representing osimertinib. So if you look at the median DFS, it was 65.8 months compared to only 22 months in the placebo arms. As to say, it was tripling. There were tripling of median DFS with the use of adjuvant osimertinib. And if we look at the DFS probability in overall population, so median DFS 65.8 and placebo was 28.1 months. So if we look at the 4-year DFS, so they were consistent for osimertinib benefit across disease stage. If we see in stage 1B, it was 80 months, 80% versus 59%. In stage 2, it was 74% versus 42%. In stage 3A, it was 65% versus 14%. So obviously, the prognosis was better in stage 1 compared to stage 2, which was better compared to stage 3A. But the benefit of osimertinib was consistent in all the disease stages. And the hazard ratio for DFS was 0.41, 0.34, 0.20, which was significant. And the hazard ratio was the best in stage 3A. So it somewhat indicates the benefit of osimertinib is there in across all stages, but the maximum benefit is derived in the advanced stages, that is stage 3A, because the risk of recurrence is also the highest in that. If we look at the forest plot, we see the DFS benefit in various subgroups. So according to the sex, age, smoking history, race, stage, and EGFR mutation, the kind of EGFR mutation and adjuvant chemotherapy. In across all subgroup, there was significant benefit of adding osimertinib. Here we see that the benefit was more in exon 19 deletion subgroup compared to L858R mutation, but the benefit was nonetheless there, and so the treatment is still should be given. So if we look at for stage 2 and 3 8 digits overall survival, so curve initially they start to separate nicely, but later on they merge. So median OS was not reached in either arm, and hazard ratio was 0.4, although the mature data was not there. EGFR TK in the adjuvant EGFR setting. So previously there have been many other trials in which the DFS benefit was shown, but no OS benefit has been demonstrated. So there was select trial, which was trial of erlotinib in the similar setting. Then we had Radiant trial evaluating erlotinib. Then we had EVAN trial, adjuvant CTONG trial, in which geftinib was evaluated, and then BR.19 trial, in which also geftinib was evaluated. In all these trials, we see clinically meaningful DFS improvement was seen, but there was no clear OS benefit in either of the data. Osimertinib was the first trial which showed a significant DFS benefit. ADAURA, the type of recurrence is the key consideration in resected NSCLC. So local versus distant recurrence has an impact on patient outcome post-surgery. So we know that local or regional recurrence is obviously better than distant recurrence, and preventing CNS recurrence is also an area that is of unmet need. CNS is a common site of distant recurrence among patients with EGFR mutated NSCLC who receive EGFR TKI. In the adjuvant Radiant study, as previously discussed with erlotinib, 7% of the recurrences in patients with EGFR mutated NSCLC treated with erlotinib had CNS involvement. Osimertinib has been shown to achieve clinically significant exposure in the brain compared with other EGFR TKIs and has shown greater penetration of the blood-brain barrier. In the advanced NSCLC setting, first-line osimertinib demonstrated superior OS and a 52% reduction in the risk of CNS progression compared to erlotinib and geftinib. We are talking about FLORA trial here. In ADAURA, we see the type of disease recurrence. 11% of the patient in the osimertinib arm had DFS event versus 46% in the placebo arm. In the osimertinib arm, the majority of the patient with recurrence had local regional recurrence only, with only 38% patient having metastatic recurrence versus compared with 61% in the placebo arm. So basically, to conclude, we can say that osimertinib is preventing more of the distant recurrences, and more number of patients have local or regional recurrence, while patients who are receiving placebo, they had more of distant recurrences. So site of disease recurrence, if we see, in both the arms, we see that the lung was the most common site of recurrence, followed by lymph node. The CNS recurrence rate was particularly low with osimertinib, and the most common first site of recurrence were nodes, lymph node, and CNS in the osimertinib group, and lung and lymph node and CNS in the placebo group. Particularly talking about CNS DFS event in stage 2 and 3A disease. So overall 63 patients had CNS DFS event. 3 patients were on treatment at the time of CNS recurrence with osimertinib versus 29 patients with placebo. If we see the Kaplan-Meier curve, the CNS DFS probability, so curves are separating nicely, and osimertinib seems to be efficacious and also prevents the CNS DFS events. We're talking about the safety, as we all know with the personal experience that osimertinib is a well-tolerated drug, and overall 66% of the patient completed 3 years of osimertinib therapy compared with only 41% patient in placebo, and the median total duration of exposure was 35.8 months in the osimertinib versus 25.1 months in the placebo arm. So we see that grade 3 or more adverse event, if we see, only 23% patient had any grade 3 event, and any serious adverse event was in 20% of the patient. 13% patient had to discontinue osimertinib, while 12% patient having to have the dose reduction. And adverse event possibly causally related, we see. So 11% of the patient but possibly caused. And the placebo arm, we see the similar data. So overall, we can see that 23% of the patient had osimertinib toxicity grade 3 or more. If we look at the type of toxicity, so diarrhea was there, paronychia, dry skin, pruritus, cough, stomatitis, and interstitial lung disease was reported in 11, that is 3% of the patient, which is a side effect of concern in the osimertinib arm, which were all grade 1 and 2. And QTC prolongation were reported in 9% of the patients in osimertinib arm and 2% of the patient in the placebo arm. So we had long-term follow-up of the same, that the post-operative chemotherapy used in outcomes from ADAURA. So overall, 60% of the patient received adjuvant chemotherapy for a median duration of 4 cycles consistent across treatment arms, and the majority of the patient received platinum-based chemotherapy, most with the stage 2, 3A disease and fewer with the stage 1B disease. Adjuvant chemotherapy use were more frequent in patients aged less than 70 years and patients enrolled in Asia, and it was not influenced by WHO PS. So if we see, so with adjuvant chemotherapy or without adjuvant chemotherapy, we see the benefit was there in both the population who has received with chemotherapy or without chemotherapy. So we can say that osimertinib was working in both the arms. So benefit was derived not because of the chemotherapy, but because of the osimertinib. So DFS in patient with or without chemotherapy will look according to the disease stage. And so we see the benefit is there across all stages, whether adjuvant chemotherapy was given or not. If we look at the DFS benefit patient with and without adjuvant chemotherapy, in particular in stage 1B, we see that the curves are separating in both the panel with adjuvant chemotherapy or without adjuvant chemotherapy, and osimertinib benefit was there with the hazard ratio of 0.38. In stage 2, the similar benefit was there, and stage 3A benefit was even more. So if we look at all these three curves, we see that the separation of curve is improving with the advancement of a stage, suggesting that the benefit of osimertinib is the maximum in stage 3. Now, we had another published report of patient-reported outcomes from ADAURA, osimertinib as adjuvant therapy in patient with resected EGFR mutated NSCLC. So when we look at the health-related quality of life method, so in this survey, we see the two components like physical component summary and mental component summary were taken. And the data collection period was as post-surgery after chemotherapy as given. Then the randomization week 12 and week 24, and then every 24 weeks. The scoring was done until disease recurrence, treatment completion, or treatment discontinuation, whatever comes first. So if we see that the overall compliance rate with the SF36 health survey was high in both the osimertinib arm and the placebo arm. Time to deterioration of physical and mental component summary. So during the disease-free period, the majority of the patient did not experience a clinically meaningful deterioration in the physical or mental component of QOL. And for those patients who had deterioration, there were no difference in the TTD of PCS or MCS. So we can say that quality of life in these patients was similar to the patient who were receiving placebo, so as to say that the osimertinib is not causing any deterioration in quality of life, be it the physical aspect or the mental aspect. To summarize, so in the DFS analysis of osimertinib versus placebo, patients have been followed for a further 2 years and all had the opportunity to complete 3 years of planned study treatment. Overall, there was a significant 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo, hazard ratio of 0.23 in the stage 2 to 3A population, and median DFS was 65.8 months in the osimertinib arm and 22 months in the placebo arm. There were also a 73% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo with DFS of 0.27 in overall population, in which the stage 1B was also clubbed together. And improvement in DFS was seen regardless of whether patient received prior adjuvant chemotherapy or not. And DFS benefit across disease stages were consistent following restaging based on HCC 8th edition. And osimertinib demonstrated a clearly meaningful improvement in the CNS DFS. And safety profile of osimertinib was consistent with the established safety profile of osimertinib, and there were no new safety concerns with extended treatment duration, and median total duration of exposure to osimertinib was 35.8 months. So the total planned duration of therapy was 3 years, and the median total duration of exposure was 35.8 months. So almost all the patients could receive 3 years of osimertinib as planned. So these data reinforce adjuvant osimertinib as the standard of care for patients with EGFR mutated stage 1B to 3A NSCLC after complete tumor resection with or without adjuvant chemotherapy, although I feel the most of the patients do receive adjuvant chemotherapy in our setting. Thank you. So any question? I'll be happy to take if there are any questions. Yeah, so if there are no questions, so I think we can move ahead over to the organizers.
Thank you, Dr. Kapil.
Yeah.
So if there are no questions, we can conclude the
So
meeting.
there is a one question from Dr. Kamal. He's asking whether osimertinib to be given with chemotherapy and can we give it after 4 cycles of chemotherapy? Yes, Dr. Kamal, osimertinib is not given with chemotherapy. First, we finish 4 cycles of pemetrexed and carboplatin. Only after that, we start osimertinib. So usually we keep a gap of 3 to 4 weeks before starting osimertinib after finishing all chemotherapy, and that was the trial design, and that is how we all practice. And so, no, we do not start it upfront. First, we finish chemotherapy and then we start on osimertinib. Only if we deem that the patient is not suitable for chemotherapy, or if the surgical resection recovery is delayed, or patient has nephropathy due to which, or any other cause due to which we, or sometimes we start with cycle 1 of pemetrexed and carboplatin and patient develops stage 3 or stage 4 toxicity, and we decide that a patient not to go ahead with further cycle, then only we can start osimertinib, and then also we take a gap of 3 to 4 weeks before starting osimertinib. And so I think that is explanation from my side. Any other oncologist who has any different practice or any other difference of opinion? Yeah, so that is it. And so I think now we are heading toward the end of this symposium. So I thank all the eminent speaker, uh, Dr. Sakib, Dr. Anshul, and Dr. Rakesh Sharma for taking time out of their busy schedule, and having them here was a pleasure. And we had a good discussion, fruitful discussion. And because the lung cancer is such a evolving area, and evolving area with the new therapies coming up every few months, and especially with the advent of drugs like osimertinib, because it radically changed the treatment paradigm of NSCLC, specifically in the adjuvant setting as well in the metastatic setting. And now that the Flora 2 trial further coming up, so I feel the new changes are bound to happen. So in the future also, we'll be keep doing these sessions so that the oncology community in country is educated, and we can have good patient management. Over to organizers.
Thank you, Dr. Kapil. So if there are no further questions, we can close the meeting with your permission.
Yeah, please. Good night, everyone. So it was a lovely webinar.